Sorry about the technical problems that I can't, that I have to do this on my phone because the NHS computer I'm using doesn't allow Zoom. So that's why the screen is wobbling a bit, but it's very nice to meet you all. I'm sorry I can't see your faces and don't know where you're from. And this is very much a general talk aimed at all healthcare professionals and parents and teachers and physios and everything. I'll just introduce myself a bit more. I'm a paediatrician. I'm actually a hospital paediatrician, and I worked for 25 years in Durham. And over those years, I got an interest in ME. Okay, so basically, I was aiming some of this at GPs and hospital doctors, but the diagnosis is not a prerogative only of doctors, and I like to feel that teachers and PE teachers in particular and members of the public can all get a good idea that a child has ME, and I think their opinions are always worth listening to. I'd like to demystify the whole question of diagnosis. A lot of doctors are sort of scared of making the diagnosis, but I'd like to say that any decent doctor who has got basic training in how to take a history should be part of the core competence of all doctors to be able to make the diagnosis. We can talk about management differently, but diagnosis, any doctor should be able to diagnose it. And I like to say that you could, that I could teach a 10-year-old Boy Scout in half an hour how to diagnose ME. Could I have next slide, please? So, and before that, we need to have some basic premises. You'll all be aware that for too many years now, the psychiatrists have invaded this territory and have tried to claim that there's no such thing as ME and that it's all due to an initial virus infection followed by the patient resting too much because of abnormal illness beliefs, and that this leads them to become deconditioned, and therefore there's a 100% chance they will be cured by graded exercise and cognitive behavioral therapy. And this falsehood has been around for too long. I'm glad to say that the new NICE guidelines are about to ditch graded exercise and CBT as curative treatments. And basically, the psychosocial hypothesis, I shouldn't really call it bio, because the people who promulgate this forget the bio and make it a totally psychiatric disease. That should be confined to the dustbin of history. And graded exercise therapy is not just ineffective, it is actually positively harmful. And that is the graded exercise that is actually pushing through the pain and doing 10% more a week, which is absolutely, it should never be prescribed. It is so damaging. You can get away with it with a very mild convalescent person, but otherwise it should not be prescribed. And I think new guidelines are going to say that. Let me just check my connection because my battery's gone a bit flat. Next slide, please. So as I've said, the ability to diagnose ME should be part of the core competence of all doctors. You shouldn't have to send them to a super specialist about it. And the ability to manage it should also be perfectly easy for the majority of cases for GPs and DGH specialists. And I personally have always questioned the need for super specialist services, which are usually too far away from where the patient is invalided anyway. Next slide, please. Right, yeah, okay. A lot of doctors talk as if diagnosis is a process of exclusion, and obviously you have to exclude certain all conditions that mimic it positively. and not just it's going to have tests for it, and you have to, and the clinical diagnosis is based almost entirely on taking a thorough history. There's no need for absolute certainty, and some of the textbook definitions, which are gold standard definitions, which say you have to have it for 3 months or 6 months before you can utter the word, are not helpful in clinical practice. And in some cases, like the very acute onset severe cases, you can begin to think of it as a possible diagnosis in the first few weeks. And similarly, I think cases that are relatively mild, that are only maybe 30% impaired, can still be, you have to be more than 50% impaired. So I think we should be pragmatic in the way we use the diagnosis in actual clinical practice. The diagnosis in young people is actually easier than in adults because there's less of a differential diagnosis, and there are no definite physical signs in this condition apart from marked facial pallor of a translucent nature. And I can sometimes guess that a patient has got ME as they come into the consulting room. And I was once giving a lecture to a group of families with ME, and I looked down and saw all the parents with ruddy complexions, and scattered through the room were lots of little pale faces of their ME children. Next slide, please. And these are the cardinal symptoms, and I think a 10-year-old Boy Scout could get this right. I don't actually like the word fatigue. I call it reduced energy levels, and basically the key thing, which I've put in capitals, is the existence of post-exertional malaise. And post-exertional malaise is the cardinal symptom of ME. And it means that after you do something, all your symptoms, including your fatigue and your pain and your brain fog, they all get worse. And some of the research on graded exercise has not used this post-exertional malaise as a cardinal feature. And I think some of their patients who might have been helped by graded exercise were not suffering from ME, but were suffering from depression, which of course is helpful. Exercise is helpful for. Next, please. And then there's a long list of other symptoms. One patient came and gave me a list of 19 symptoms, and she hadn't even put fatigue on it. And myalgia, muscle pain, and general pains all over the body, abdominal pain. About 90% of them have quite severe headache. And sometimes on top of the continuous low-grade headache of ME, there's quite a lot of them actually have migraine, and it's well worth looking for migraine as something that you could probably treat a little bit and take the edge off many of their symptoms. Sleep disturbance is very common. In the early acute stages, they tend to have hypersomnolence. I know a girl who slept 23 hours out of 24 for 9 months. And as they progress and convalesce, they have a very remarkable condition called sleep reversal. And they can't get to sleep till, say, 2 or 3 a.m. And then they sleep through for about 12 hours until mid-afternoon. The cognitive dysfunction is really, really impressive. You get mild cases where the kids' grades are falling at school and they can't concentrate and their short-term memory goes. And parents will tell you, I asked her to go to the shop to buy something and she forgot what it was when she came back. And we call this brain fog. I know some adult cases where it was the most incapacitating of all the symptoms and actually led to the person losing their job, even though their fatigue wasn't that bad. There was a lot of autonomic dysfunction. The children often complain of feeling too hot or too cold. One psychiatrist showed a photo of a boy in August wearing his mother's fur coat, and to use this as a joke to show what a fake so many ME patients were. Whereas I would have taken it to mean that he actually felt too cold in August, and that's why he was wearing the fur coat. The other things, they can have dizziness and orthostatic hypertension. There's an interesting condition called POTS, postural orthostatic tachycardia syndrome, which is amenable to further treatment. And not in most definitions or in most textbooks, I've noticed that people with ME, often quite mildly, can have, every time they get a virus, it lights up all their ME symptoms, and the virus hangs around for 3 or 4 weeks. And they, in other words, it's not that their immunity is down, but that the virus seems to trigger all the other symptoms into reactivation. So that's well worth knowing. There's a boy I'll mention now for whom this was the only symptom. He was at 90% of full capacity, attending school full time. But every time he got a cold, he was off school for a month. But he didn't know he had ME, and no one would have diagnosed him as having ME. But he then went backpacking with his father in Scotland on a camping trip for 2 weeks, lugging his tent around. And that precipitated a marked relapse. And he dropped down to about 30% of severe ME. If he'd known he'd had ME, he might have been warned against going on a backpacking holiday. And another example of a mild case of ME who could be made much, much worse was a girl who'd recovered full-time schooling, 90% efficacy, brain working fine. And her paediatrician had wisely said, keep off sport. But because she used to be good at sport, she was cajoled into a cross-country run, and she did it and survived, but then suffered an 18-month relapse, which kept her off school completely. So knowing mild cases, knowing they've got ME, it's worth knowing, and it's worth diagnosing the mild case. Next slide, please. If you're dealing with families and the child has a puzzling illness and no one has a clue what it is, it's really quite liberating for them to actually be told it's ME, because nearly always the family are worried about something more serious like leukemia. Occasionally I have a teenager who objects strongly to the diagnosis and refuses to see me again, but usually people are grateful to at least know what it is and to realize that it's not something more serious. The other reason to diagnose it early, and the commonest presentation, of course, is someone who has a flu-like illness, is off school or work for 2 weeks, feels pretty awful, but then has to get back on the treadmill because they're missing so much lessons or work, and they push themselves back. And nearly always in the early case of ME, that is unwise. You have to accept the reality of this. It's a bigger condition than we are, and you need to warn people not to push themselves back to work or school too soon. Of course, children and parents are naturally prone to doing this, even without professional advice, but they need to be warned about it. As I said, you don't have to wait 4 months to make the diagnosis, and in the severe ones, you can make it early. The acute illnesses can sometimes begin with a really nasty attack of Bornholm disease, otherwise known as the devil's grip, which is due to Coxsackie B. Very nasty virus, can give you horrific chest pain, abdominal pain, generalized muscle pain. I had 2 cases where they actually thought, because it affected the paraspinous muscles, they thought it was due to kidney disease, but the kidneys were normal. And Bornholm disease, Coxsackie B, it's a famous virus for causing ME, and it's worth knowing about as well because it can cause myocarditis. Next slide, please. Management of ME. I find the biggest problem with doctors, I've never quite understood why doctors avoid diagnosing ME so much, but sometimes they say it's because we don't have a cure. And it's very important to admit that we don't have a cure. And once you've admitted you don't have a cure, you can then concentrate on other aspects of management, which I'm going to go into. And the management of ME should be the same as for any other chronic, unpleasant or disabling condition for which we have no cure. And doctors don't seem to have any trouble being nice and supportive to patients with rheumatoid arthritis or inflammatory bowel disease or diabetes or anything else. But for some reason, they seem to avoid diagnosing and managing ME. I'd like to say that once you accept there isn't a cure, but come clean with the parents and explain things to them, these families are among the most grateful that you can meet in pediatric practice. So don't be guilty about not having a cure. And beware the thrust, which is now being shown with long COVID. There must be a treatment. We need treatment centers. We want facilities. If you accept that there's no cure, then you don't have to demand treatments. And this is where all the problems with graded exercise have come from, people claiming that they have curative treatments. And the good news for children is that there's quite a good prognosis for full spontaneous recovery. And it is a better prognosis for young people than in adults. And I've got quite a few very severe cases who have made full recoveries. We can talk about possible curative treatments with immunoglobulin later, but I did have one boy who was quite severe, confined to a wheelchair, and a very wise GP nearby called Dr. Irving Spur, who is an enthusiast for ME, gave him immunoglobulin. And that severe case, then 2 years later, was back at full-time school, and he then managed to climb Snowdon, Scarfell Pike, and Ben Nevis within 24 hours and not feel any effects. And that was a full cure. And that got me interested in immunoglobulin, and I gave it to all my severe cases. Next, please. Next slide. We'll talk about these different aspects. If I could summarize all these, the first thing is this is aimed at doctors and other professionals, just be nice to the parents, nice to the families. I've got a lovely cartoon which I should have brought along, and it shows a GP surgery full of rather haggard ME patients, all looking optimistic. And their spokesperson says to the one GP on duty, "We've heard a rumor around here that one of you was once nice to someone with ME." And of course, that's another problem, that people are worried that if they start being nice to ME patients, they'll all flock to your clinic and you'll be overburdened. Okay, next slide, please. Because so many people have been subject to disbelief from parents, doctors, teachers, relatives, being believed in is one of the most important parts of management, and that's what I call validation. And a doctor who takes a very careful history where he or she shows that they're interested in every single symptom and writes it down, will be halfway there already by showing that he cares and believes in them. There's a beautiful TED talk by Abraham Verghese, who wrote Cutting for Stone, the great medical epic, and he talks about the needs of ME patients. And he said he soon realized that each patient, these are adults, have an enormous story to tell, usually of disbelief and rejection from other doctors. And he gives them an hour for the first history and then sees them the next week for the examination and investigations. It's a beautiful TED talk to Edinburgh medical students. I'm a great believer in calling it ME rather than CFS. CFS is a rather mealy-mouthed term that minimizes the illness, fails to respect all the many symptoms that can be caused, and limits it just to one symptom. And ME is stronger and more powerful and is favored by all the charities, and there isn't a charity for CFS. And I'm glad to see that NICE guidelines are now calling it ME CFS rather than CFS ME. You can imagine if you come back to school after 2 years having had ME and you tell your friends, say, "Why have you been off school?" And you say, "I've had chronic fatigue syndrome." The chap said, come off it, you skiver. That, you know, but he would say, no, it's ME. "Oh, sorry, I've heard about that. it can be really nasty. So validation and calling it ME is perfectly respectable. Next, please. As I say, just being nice is doesn't cost anything, and you don't have to worry too much about compassion fatigue, and patients and parents and families can get support and empathy from other places. I used to jokingly write the word sympathy on an NHS prescription and hand it over, and a bit of sympathy doesn't hurt anyone. Next. In paediatric ME, there's an enormous amount one can do to support the patient. The educational system is heavily involved and likely to cause trouble for children. And firstly, they have to be protected by the diagnosis. Then they need sick notes, they need special allowances, support for home tuition. And even when people go to university, I've written letters asking for the students to be given a ground floor apartment instead of the top of a tower block. I once had a boy who was gradually running out of steam Monday, Tuesday, Wednesday, and he spent Thursday, Friday, Saturday, and Sunday in bed. And I reasoned that it might make sense for him to go to school Mondays, Wednesdays, and Fridays and recover on the other days. And I actually instructed it. And I'd got an angry head teacher on the phone saying that didn't I realize there's a legal requirement to attend school 100%. And I complained to a chair of governors that there can be medical reasons. And we got an apology saying the head teacher was on a steep learning curve. But I tell this story because kids, even with protected by a diagnosis of ME from a nice, kindly paediatrician, can still suffer tremendous pressure from schools. And I had to go to Scotland recently to protect a mother from prosecution because the paediatrician's diagnosis was not strong enough to deter the school from prosecuting her. Next. Benefits, of course, and blue badges, wheelchairs. And then part of support is giving advice. And the commonest kind of advice I give is people ring up and said, should I try this or should I try that? And a lot of it, should I try acupuncture or Reiki or homeopathy or cranial osteopathy or anything? And I have a general rule that if the person who's doing it seems to be wanting to help and isn't charging too much, I certainly don't prohibit it, and I'm always delighted when anyone else cures any of my patients. Next. Yeah, sorry, I mentioned wheelchairs. And then the advice also is about budgeting one's energy reserves and getting away from graded exercise and pushing through the pain. The best model, which all the charities accept, and I think NICE guidelines are going to accept, is a philosophy called pacing. And this is called staying within your energy envelope. I did a clinic in Devon a couple of years ago, and I saw 12 families. I talked to them all about where they were and what was happening and what they're doing. And at the end of it, I summarized the advice I'd given. And in 11 out of 12 cases, I'd actually I pointed out that they were actually doing too much and that they should actually cut back a bit. And I know it's difficult when you're on the educational treadmill, but getting better from ME is more important. And you do actually increase your chances of recovery if you can get to a better situation. And the motto I use is take 2 steps backward and then take 1 step forward. Next. I was mentioning that teenage boys can be very difficult to give advice to. I think most people know that. Whereas girls make very, very good patients. Next. Yeah, we've said about always being asked about advice. Now, protection, I use the word advisedly, is really essential. And that's why ME is such a stronger term than chronic fatigue syndrome. I've mentioned the pressure in the educational system, but horrifically, I've been involved in over 100 cases of innocent families subjected to safeguarding child protection proceedings by disbelieving professionals. And this is sometimes driven by the paediatrician. It's sometimes driven by head teachers. It's quite often driven by malicious ex-husbands or wives. And when there's malice in a divorce, a child with ME is a very tempting pawn to use in a battle with your former partner. And this problem of fabricated and induced illness, what used to be called Munchausen by proxy, has become very fashionable by having spread the definition to include medically unexplained symptoms and perplexing presentations. Now, a lot of those will just be children and patients suffering from things that the doctor can't explain, and the mother isn't fabricating anything. But there seems to be a bit of an epidemic on for this, and it's very, very fashionable. And the protection the diagnosis gives you protects you from disbelief in all its forms. And it's not just professionals. There's often a member of the extended family, the ex-husband, the disapproving aunt who's a nurse, this sort of thing, and school friends as well. And I've known friendships and relationships broken up because of the strong disbelief from coming from one party. I can assure you there's nothing more horrible than an innocent family being persecuted in this way. And there was an article in the Times last summer about a family from Cumbria, and they've come out and allowed their names to be used and everything, who were hit with a case conference without any warning because the named doctor for child protection objected to the fact that they were dissociating themselves from the graded exercise that he prescribed. And because 2 out of 3 of their children had ME, he tried to make out that the mother must have invented both of them. So it is horrible. I'm glad to say usually the social services get it right and they can spot an ill child in a normal family. But it can be any of those groups of professionals driving these cases. The other kind of thing that triggers child protection is when a child with moderate ME becomes more severe, as often happens if they get a virus or something. And the doctor then panics and feels he's misdiagnosed it, and they panic and refer to psychiatry and social services. And there's a terrible label called pervasive refusal syndrome, which is applied to severe ME patients, and it's a totally psychiatric diagnosis. And it means that this patient with ME has turned from being a physical illness into a purely psychiatric illness, which of course is most unlikely. Next. And we've mentioned the strength of the term ME, and I personally wish the term chronic fatigue should be abolished, and that is the position of the ME charities. And if the doctor says, but there's no real ongoing encephalomyelitis, say, all right, call it encephalopathy because they get brain fog. But either way, it's ME. Next, please. Do we have any questions yet? I've been talking a lot. Good question, and that is one of the commonest we've been asked over the last 2 years. Let's take the flu vaccine first. I think the advice depends on the patient. There are some patients, if you take the very severe end of the spectrum, who are bedridden, lying in a darkened room, not going out, and unlikely to be exposed to anything. If their parents get the flu vaccine and are immune, the child's unlikely to get it, and you can get away with the child not having it. The reason people are a bit scared of giving vaccines to people with ME is that the vaccine could make them worse. So if you have that sort of situation, severe patient, hidden away from everywhere, low risk of infection, you can avoid it. And the same would go for the COVID vaccine. On the other hand, if there's a reasonable risk that they could catch it, then having the vaccine is almost certainly less risky than catching it. So you have to balance the risk of catching it against the risk of the vaccine making them worse. I have heard from a lot of patients who with moderate ME who've had the vaccine through the pandemic, the COVID vaccine, and they seem to have got away with it. So every case is different, and it is a very common question. Thanks. ME patients have lots of horrible symptoms, and there's quite a lot. This is not curative, it's just nibbling around the edges, trying to take the edge off some of the unpleasant symptoms. Now, next, can you just skim down? So I've already said, if you can find some migraine and treat that, that's good. Drugs like amitriptyline, carbamazepine, and gabapentin can be good for the myalgia and the limb pains. Sleep reversal can respond to melatonin. But I would warn against another thing that is becoming very fashionable in ME centers around the country. And for some reason, doctors can't tolerate the kind of sleep disturbance, the sleep reversal that I've been talking about, and they insist on sleep hygiene regimes. And these are almost universally harmful, and as harmful as graded exercise. And it's another example of people applying something that works for other conditions to ME, which is probably nearly always misguided. I'm reminded of one of our nurses in Durham. I gave a talk to the nurses in advance of a very severe case being sent to us under a court order from the south of England. So I explained to them about the disbelief, the fact that the mother will be very protective and you'd accuse her of being overprotective, the unpleasantness for the child, the stress caused by excessive sensory overload. And I did all this. And then I talked about stress of any sort, emotional, physical, noise, exercise, all making them worse. And she said to me, so you're really telling us that everything we've been taught in our nursing training for other conditions is wrong for ME? I said, absolutely, very well put. And I think sleep hygiene, physiotherapy, rehabilitation, they all sound wonderful things, but they don't apply to ME. While we're talking about physiotherapy, the main role physiotherapy has for a very severe case is gentle, just persuading the parents and explaining gentle passive movements to reduce the risk of venous thrombosis, which is very, very rare anyway, and also joint contractures. I have seen people develop joint contractures. And those which I've never personally prescribed, but other ME experts are using them around the country. And it's a drug called low-dose naltrexone, which is an opiate antagonist, which really seems helpful and is really quite an optimistic trend at the moment. Right, next, please. These are all quotes I've heard from GPs and paediatricians. We don't believe in ME in this practice. Children don't get ME. That was from a paediatrician with a 9-year-old boy with ME. I don't believe in labeling cases, which is just stupid. I don't like making a diagnosis when there's no treatment. We've mentioned that. And this is a beaut. This was a professor of pediatrics to a 6-year-old girl. But you can't have anything wrong with you because all your tests are normal. 6-year-old girl to famous professor. Perhaps I've got a condition for which you have not yet invented the correct test. I think that's game, set, and match to the 6-year-old. Next, please. Right. I had finally a medical student. They come to you for a month in Durham. And I said to him in the first clinic he came to, I hope during the month you're with me, I can convince you that ME is a genuine physical condition. He said, you don't need to convince me. He said, I've had it. I said, goodness, tell me your story. He said, well, I was up in Oxford and did my first year perfectly happily, came down with flu in the summer. And then I got worse and worse and never got back to university. And after 9 months of being virtually housebound, my friendly GP, who knew us well as a family, sent me along with a supportive letter to the local DGH to see a physician. And I expected this physician to take a history, do an examination, and come up with a diagnosis. Not a bit of it. He looked at the GP's letter, asked the nurse and other attendants to leave the room, and then in private tore a strip off this poor student saying that if he hadn't the guts to complete a university degree in these times of high unemployment, he should make way for better people, and then kicked him out. And as he limped home, we'd been studying another subject, he said to himself, I could be a better doctor than that chap, and he is. But that's the way some doctors feel you're entitled to treat people with ME. Had a 14-year-old girl in Scotland with moderate ME, and she got worse, and the paediatrician panicked and sent her to a child psychiatrist, and the child psychiatrist changed the diagnosis to pervasive refusal syndrome. This girl was in severe pain every time, and she was highly sensitive to noise. She was tube fed. Every time a door slammed, her whole body jerked because of her hypersensitivity, and she was very, very ill. But she was changed to a psychiatric diagnosis, had a court order, and compelled to go into a psychiatric unit. And the psychiatrist prohibited her from having ear defenders or wearing eye shades to protect her from her light sensitivity. She said she had to be desensitized by being exposed to these things. And that's what happens if you refer people to psychiatrists who have got a physical illness. I've forgotten what the next one is, but the GP, this is a sad story. In the southwest of England, a GP rang an ME helpline and said, I'm really worried, I think I might have ME. And the helpline said, oh, why are you so specially worried? He said, well, you don't realize in our practice, it's been policy for a long time to treat ME patients with absolute ridicule, rejection, and just kick them out. And he said, I can't tell my colleagues that I've now got it because I'm so scared. He said, I'm going to take early retirement and tell them I've got depression, which he regarded as less of a stigma. Now, that was within the last 2 years, and that's the way some doctors still think about ME. Most of you probably have heard of the famous Isle of Man case, a 12-year-old boy diagnosed with ME, referred to London, diagnosis confirmed. Famous child psychiatrist intervenes, says it's not ME, said it's fabricated by the mother, court order taken, protected parents' access to that child limited, and the final straw was because of the disbelief engendered by this child psychiatrist, he was thrown into a hydrotherapy pool to prove he was a fake, as a variation of the medieval test for witchcraft. He failed the test and nearly drowned and had to be pulled out. There's a video of him as a young adult looking at the hospital on the Isle of Man where that happened. Next, please. GPs can be fantastically supportive. I was involved in a case in Enniskillen about 10 years ago of a very severely ill girl, and she got worse and worse. And when she was left from Paediatrics on her 16th birthday, she went home and was looked after only by the GP. And I saw this girl at home to support the GP. He couldn't get any physician from the local DGH to show the slightest interest. And this GP had to handle a girl who was only sleeping for 4 hours a day, who was in total body pain, who had myoclonic jerks every 20 minutes, who was tube fed, catheterized on a ripple bed, nursed at home. And he tried different drugs to help her, had her on opiates and all sorts of things. And he was the only person supporting that girl. And I don't know, I fear what would have happened to her if that GP hadn't been so brave and broad-shouldered. I had I forget about that one. And then one of my first severe cases, who was bedridden and tube-fed for 3 years, I was visiting her monthly, but she got a nice new GP with a lovely persona who got up a relationship with her, and we shared alternate months visiting. And between us, we helped her through to recovery, to a spontaneous recovery. We didn't cure her. And the other thing is, as with all chronic illness, don't underestimate the value of simply seeing your patients again. Don't say there's no point seeing you because I don't have a cure. They deserve support. they can also develop other conditions, and you can always keep an eye on whether you've missed any other diagnosis. So I think every ME patient deserves continuity of care from one dedicated doctor. Well, I personally am a great believer in exercise, and I've run 20 half marathons and 7 marathons, and I'm a great believer in it. And I love it when my patients recover enough to do those things, like climbing those mountains. In my experience, as children recover, they don't need any advice from me to do more exercise than they feel like doing. In other words, all my patients seem to be able to handle their own convalescence without outside advice. And I've never found a case where I personally felt like encouraging a child or young person to do more than they were doing. As I've already said, the natural tendency for children as they recover is to blow it and to do too much. So I don't personally see a group of patients who would suffer from being deprived of outside advice as to how much exercise to do. I heard an adult ME specialist say that in her experience, again, adult patients all tend to do too much rather than too little. There may be isolated exceptions, but I've never felt like telling any of my ME patients to do more than they were doing. To the question of home visits, I'm also the medical advisor to the 25% group, which represents the severe end of the spectrum of ME. And it's horrific how many severe cases of ME are bedridden at home and abandoned by both their GPs and hospital specialists. And I always used to justify the idea that the GP calls in a consultant to do a domiciliary, and these cases should be allowed home visits. I had a case of a very severe bedridden, tube-fed girl in the southwest, and the GP said our policy is only to do home visits for people with broken long bones and terminal cancer. So I thought that was rather sad. My battery is getting, this charger is useless. Next slide, please. We've already said GPs can feel helpless. Sometimes they are filling a vacuum left by the hospital, especially with the severe cases. I've mentioned 1 or 2 examples. And sometimes when families are being persecuted by child protection agencies, it can be fantastic. I know 2 cases where who knew the family well came to his worth his or her way to go. Next slide. This is a slide of a third of a sample of 49 patients who over 6 years all made total recoveries. When I've said those made total recoveries without any extra help from anyone, those were spontaneous recoveries. They didn't have psychology, they didn't have graded exercise, they didn't have a physiotherapy or anything. And that's the optimistic side of ME. And some of them were, pretty severe in that pink zone. Next one, next slide. And this is the more depressing side. And 7 of the 49 got worse. The one who descended steeply from the top is the boy who went backpacking, not knowing in Scotland, not knowing that he had ME. Again, look at the tremendous ups and downs and the remissions and relapses. Next. And these are a large number in between, but I'm glad to say many of those have made good recoveries subsequently. And you see the girl who was tube-fed, bedridden for 3 years. She's now working and is married and has a child. And so even the severe cases can make full recoveries in time. If my battery goes completely flat, I say goodbye and sorry, but this charger is not working. And I keep holding it and pushing it. Next slide, please. Good, so that's where we can finish unless there are more questions, but I have got to go on to say something else. but we've only got 5 minutes anyway, so any other questions? I apologize if I've been slightly oversimplifying and dogmatic for a very complicated issue. The traditional case of ME is a post-viral illness, and as you know, a lot of long COVIDs now are very like ME, and that is a post-viral illness. There's some weird things developing in terms of other possible causes, and of course, not every case of ME is actually ME, and you have to watch out for being caught out. I missed a case once of narcolepsy, and the mother put me right eventually because the boy was falling asleep at school. And the other thing that's very confusing is the atypical infections, such as Lyme disease. And one of my cases I'd been treating as ME or not treating as ME turned out to have almost certain Lyme disease. So the overlap with Lyme disease and also Ehlers-Danlos syndrome and hypermobility is a whole area that I don't understand. And there's some weird things coming from America about cervical, craniocervical instability in the vertebrae, which needs neurosurgery. And that is probably important for a very small number of patients. But I did see a girl who developed ME following a whiplash injury, another one who developed it following a skiing accident, another one who developed it falling off an ME, or falling off a horse. And the girl who had the skiing accident, I lifted her jaw, I lifted her head up off her neck, and she said, "Gosh, that feels better," as if she had damaged her neck and the circulation to the brainstem. So it's a very confusing area on the edges, but the classical picture of most ME, as you know, it all developed following a viral epidemic in 1956 in the north of London with royal free disease. So most ME is viral, and there's some differential diagnoses, and there's some overlap with other confusing conditions. Hope that hasn't made it worse. It's a very unpredictable condition, and I think mildness of the disease, the milder the disease, the better your chance of recovery. And I do occasionally, tell people in the mild area that they have a very, very good chance of total recovery. But another virus hitting them or glandular fever coming along, it's difficult to predict. But I do inject cautious optimism for full recovery in mild cases. And then the ones who are very severe, again, I tell them, well, you might still make a good full recovery. Thank you all for listening, and I'm sorry I wasn't able to interact with you more. If anyone had any extra questions they think of later, I'd be very happy for you to email me. My email address is Speight, S-P-E-I-G-H-T, Speight at doctors, that's doctors, D-O-C-T-O-R-S, .org.uk. I'm always happy to talk to people.